We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Vulvar Premalignant Lesions and its Identification Management, organized by Tnfog and Madurai OBGYN Society. So let us start the webinar. So it's my privilege to introduce the MOC of today's webinar, Dr. Radhika Gauri ma'am. Ma'am is the specialist consultant in OBG and clinical lead at ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to you.
Good evening, esteemed faculty and all delegates. So we are moving into the next session of Tnfog on vulvar lesions. I invite Dr. Padma ma'am, who is our organizer, to give the welcome address. Dr. Padma ma'am is Senior Consultant HOD of Meenakshi Mission Hospital and Research Center, Madurai, Tamil Nadu. And she has done her fellowship in Obs and Gynae Oncology, Netherlands.
Okay, Shahiti, we'll move ahead. Huh?
Yes, ma'am.
Yeah. Thank you. Good evening and welcome to the Tnfog Oncology Committee's webinar, the 6th one we are conducting this year. And usually this meeting is usually held in the last week of every month, but for various logistic reasons, we have moved it today to the first Saturday. And so far, we have been focusing on the premalignant lesions of the genital tract, cervix, endometrium, GTN, etc. in the past. And as a continuation of that, and to benefit our general gynecologists as well as the oncologist, we are focusing now today on the vulval lesions. And as a woman, whenever they have a vulval lesions, they are worried. The main concern is it a, what do you say, a STD? Is it a part of an STD? Or is it a premalignant condition? That's what they are worried about. And for the same reasons, they are a little hesitant to seek help earlier also. And but we all know the lesions of the vulva can be a part of the general, disease, systemic disease, dermatological problem, or it can even be a contact dermatitis, STDs, premalignant lesions. And the vulval lesions also are a part of, most of the vulval lesions also are of HPV in etiology. That's a field disease, isn't it? We all know that cervix, vulva, vagina, perianal region, all this come as a part of that. And with the better understanding of the disease, the terminologies and classification of the vulval disease also are getting updated periodically. And today we have Dr. Arpita, Associate Professor from the Department of Gynae Oncology, JIPMA, which has a huge volume of these sort of cases. And she will be delivering the lecture on vulval premalignant lesions, identification and management. Identification is the most important part. And once it is done, then the patient gets the appropriate guidance and gets referred to the appropriate gynae oncology center and gets managed in a better way. And today we have two eminent teachers, professors, Dr. Chandru Ramachandran Madam from Madurai and Dr. TV Chitra Madam from Coimbatore, who will be chairing the sessions. And with great pleasure, I am inviting today Dr. Sampath Kumari Madam, the Secretary of Tnfog. She has joined us today, and I request Madam to say a few words.
Yes, thank you, Dr. Padma. I welcome you all for this oncology program, CME webinar, which is organized by Tamil Nadu Federation of Obstetrics and Gynecological Societies and Madurai Society. Dr. Padma is our chairperson of our Tnfog Oncology Committee, and she is doing this program continuously every month. As she told, she has covered each organ, that is endometrium, uterus. Now today we have the vulval premalignant lesions and how to evaluate. So this program is welcomed by many people. Now the oncology, there are many people joining the fellowships and the MCH courses, and with the continuation of this program, once Dr. Padma has finished all the gynae oncology topics, we will make this as a certificate course. Already we are conducting 4 certificate course in TNFOG. One is with the fetal medicine, and another with the labor, and another one with infertility. So we are planning to make a certificate course on the oncology also. So I should thank Dr. Padma for taking effort, and she is bringing the wonderful speakers. Now we have the wonderful speaker, Dr. Arpita from Zipman, and our teachers, Dr. Sinduru Madam and Chitra Madam, being sharing the talk. So once again, I welcome you all. Hope you all will be benefited by this webinar. Thank you, Dr. Padma, and all the delegates and the faculties. Thanks for attending this program. Thank you.
Thank you. And actually, Madam has organized Oxy Oncology program next Saturday. So those of you who are viewing and then interested in joining.
Padma, 1 minute, I will inform that also. I forgot. I thought I should inform. See, that is on September 14th. We are having the only CME exclusively for oncology. There we have the oncology committee chairperson from Tnfog, Asia Oceanic Federation, as our chief guest. Dr. Koyusu is coming from Hong Kong. So whoever is interested can please join in that CME that is to be conducted in 4 Point Sheraton Hotel at Chennai. The registration is free, but it is mandatory that you should do it 2 days earlier itself. So I welcome you all for that CME, which will cover all the gynae oncology, and we have fantastic speakers from outside national and international. Thank you all. Welcome you all. Padma is giving a talk. Chitra Madam, you also people from Coimbatore, and Chenduru Madam, and all of you, please join that webinar that starts by 9 o'clock. September 15th.
Nice. Oncology is becoming a more interesting subject nowadays.
Yes, madam.
Welcome, Revati Madam.
Thank you.
Madam, welcome. Revati Madam, good evening.
Good evening. Yeah.
Sambat Kumari Madam, good evening.
Good evening, Chandru.
Good evening.
Okay. So, can the chairpersons take the lead from now on?
Okay. A warm good evening to you all. At the outset, I thank Dr. Padma, Secretary Mogs, and Tnfog Oncology Committee for this invite. The topic is vulvar premalignant lesions, identification and management. So early identification and management can prevent the progression to invasive cancer and improve the outcome. And therefore, regular checkups and biopsy are essential in high-risk patients. The incidence of vulvar premalignant lesions are increasing, particularly in younger women, largely because of the HPV infections. But however, with awareness and availability of HPV vaccines, especially the nanovalent Gardasil 9, the overall incidence has been significantly on a decrease in younger women after the introduction of the HPV vaccination programs. Now I invite Dr. Arpita, Associate Professor Gynec Oncology, JIPMA Puducherry, to deliver her talk on this. And I request Dr. Chitra to introduce the speaker.
Okay. At the outset, let me thank Dr. Padma and Tnfog for having given us this opportunity. It's indeed my pleasure to introduce Dr. Arpita. She's looking so young in this photograph. So welcome, Dr. Arpita. She's an associate professor, Department of ONG, JIPMA Pondicherry. Her area of interest is preventive oncology, device development for cervical cancer screening, and implementation and qualitative research. So very short CV. So welcome, Dr. Arpita, for talking to us about this very useful and important topic of vulval malignancy. Like how Dr. Sendura told, many people will come with some discomfort, and we tend to ignore them. They might be having pruritus, but I think it's diabetes, pruritus, etc. So it's very important that we have a high degree of suspicion, and we try to identify these lesions from whether it's benign lesions or normal lesion. So it's very important that we try to find out is it normal dermatological lesion or pre-malignant condition. I'm sure Dr. Arpita will be able to throw some light on it so that we don't miss these conditions, because we might be the first contact. Only if we're able to make a diagnosis, we'll be able to refer them, do the whatever is necessary and refer them to an oncologist. Over to Dr. Arpita for giving her talk.
Thank you, dignitaries. I would like to thank all the organizing members from Tamil Nadu Obsgynae Society and also Madurai Obsgynae, Padma ma'am, and all the teachers in the forum. Happy Teachers' Day to all of you. In front of you, giving this talk is actually is a blessing also. Thank you so much for the opportunity. So, can I share the slide, please? Yes, ma'am. Is it visible? Is the slide visible?
Yeah, seen.
Okay. So, my talk is on pre-invasive lesions of vulva, identification and management. Basically, I focused only on vulval pre-malignant lesions. I have not gone into dermatosis of vulva. If time permits, I will talk about it. Otherwise, I will stick only with the pre-invasive lesions of vulva. So, I will be covering as to what is the classification, risk factors, natural history, clinical presentation, diagnosis, treatment, and surveillance. So, pre-malignant lesion of vulva, we mean as any abnormal cell changes that happen in the vulval skin, which have potential to develop into an invasive vulvar cancer if left untreated. So, this is how the biopsy will look like, where you can see there is increased nuclear cytoplasmic ratio and nuclear crowding in the base, starting from the basal epithelium and heading towards the superficial layer, whereas the basement membrane is still intact and there is no invasion seen. So, vulval intraepithelial lesions were previously referred to as VIN, the new terminology as vulvar squamous intraepithelial lesions. These are a group of pre-malignant conditions, which, can you hold on? This is my another slide which is coming on. I'll just change the slide. There's some problem with the slides.
Any problem, Arpita?
The slide which I wanted to show, it's not there. Maybe it is not saved. The latest version is not this. Okay, the study based on US National Cancer Database says that approximately 2.8 for every 1 lakh females have vulval intraepithelial lesion, but actually speaking, it is underrated and the incidence is actually increasing. And prevalence of this squamous intraepithelial lesion is higher in the premenopausal lady compared to that of postmenopausal patients. Perimenopausal, more to be specific. So the terminologies have been evolved over past few decades. The International Society for the Study of Vulvovaginal Diseases, latest by 2015, have classified pre-malignant lesion as LCIL of vulva, that is flat condyloma, that is HPV effect, or HCIL vulva, that is vulvar HCIL, VIN usual type, or a differentiated VIN. So the latest terminology is HCIL usual type VIN or differentiated VIN. LCIL is still just an infection from HPV. So, but pathology-wise, the better understanding is with 2004 ISSSVD classification, where VIN usual type is classified into Wati type, Basiloid type, and mixed variety. So I will be dealing with each type further in the slides. So the main focus is usual type VIN, that is HPV associated UVIN, or a differentiated VIN, that is DVIN, which is HPV independent. So what are the differences between these two? The usual type of VIN accounts for nearly 95% of pre-malignant lesions, they are HPV associated, either 16, 18 HPV serotypes. And age group of women who are affected by usual type of VIN are usually young, aging from 20 to 40 years. And the risk factors are again HPV dependent, that is multiple sexual partners, early onset of sexual activity, smoking, or immunosuppression. Histological types, they might be warty type, basiloid type, and a mixed variety. Differentiated VIN accounts to lesser amount of premalignant lesions. They are not HPV associated. They are usually seen in older women, typically more than 60 years, that is postmenopausal. And usually the background or the risk factor is chronic dermatosis, most likely lichen sclerosis. And they don't have any subtype. And they are mainly associated with basal atypia of the basement near the squamous epithelial cells. So when you see the histopathology, in the basiloid type, you can see an uniform immature basiloid cells occupying the entire epithelium and with increased nuclear cytoplasmic ratio. That is the image in A, it's the basiloid type. Whereas in B, that is warty type, there is prominent papillary architecture and chylocytic changes. In a mixed variety, you can see both basiloid pattern and a warty pattern. Hello? So that the image D tells the IHC marker with P16, whereas there is diffuse uptake. Again, indirectly telling to us that it is P16 diffuse positivity, which is again HPV dependent. In differentiated VIN, you can see that the abnormal chylocytic differences are near the basal layer, whereas the upper third of the epithelium is preserved. So picking up these lesions is actually very tricky and it is more likely to be missed. So easily overlooked lesions. So these the lesions which are seen in these boxes and in circled areas are subtle basal atypia, which can be easily overlooked. So pathologists play a vital role in the biopsies of BVIN. So it has to be particularly biopsied in the area of suspicion, and the cross section also has to be studied with more amount of time given to it. So coming to the pathogenesis, the normal vulvar epithelium, either when affected by HPV, E6, E7 subunits of HPV will attack the tumor suppressor genes, that is RB gene and P53, causing abnormal hyperproliferation or loss of tumor suppression, again leading to proliferation of epithelium. So, whereas in the background of lichen sclerosis or a lichen planus, that is differentiated VIN, there is a mutation occurring directly with P53, which again leads to abnormal proliferation. We can see that a usual type of VIN usually proceeds towards squamous cell carcinoma at a rate of means the chance of progression to squamous cell carcinoma is nearly 6%, whereas in a differentiated VIN, it is still much more higher. It is 33%. It is though less in incidence, easily missed, but the rate of proliferation or a progression to squamous cell carcinoma is pretty high. That is approximately 33%. Again, coming to the differences with the symptoms of the first column is usual type of VIN, the second is differentiated VIN. The usual type of VIN is often symptomatic and it presents with itching, burning, or discomfort, whereas a differentiated VIN is usually asymptomatic or they present with mild symptoms. The location of a usual type of VIN is usually in the posterior vulva or in the perineum, whereas a differentiated VIN is usually in the labia minora or interlabial sulci. As I told previously, the progression to cancer is lesser in terms of usual type of VIN, that is 5 to 10%, whereas a differentiated VIN is higher. It is nearly 33%, which or 30 to 50%. Again, histopathology, there is full thickness atypia and mitosis throughout the epithelium in usual type, whereas in differentiated type, the atypia is remitted to the basal layer with maturation above. So this maturation is not lost in usual type of VIN. So this is this is the reason why most of the differentiated VIN is missed. HPV DNA dependent in usual type of VIN, whereas independent in differentiated VIN. Coming to the management of these two varieties, usual type of VIN, either you can treat by excision or by ablation with laser, or by treatment immunosuppressors with imipamode or photodynamic therapy can be given. Whereas differentiated VIN, since it has a higher risk of progression, excision is usually preferred. Coming to the recurrence, since it is usually common, approximately 30 to 50%, especially with immunosuppression, immunosuppressed people, usual type of VIN do recur. It's also common with differentiated VIN, but high vigilance is required because it might progress into a carcinoma. Coming to the prevention, since it is HPV dependent, HPV vaccination is effective in preventing usual type of VIN, whereas differentiated VIN is usually you have to control the underlying dermatosis, or you have to treat the underlying dermatosis, and there is no vaccine for it. This is about two main types of VIN. Coming again with the risk factors, HPV is the majority of the cases, HPV is associated risk factor. And the associated risk factors of sexual contact, genital, oral, or anal contact with vulva. And the subtypes associated is again 16 and 18. The low grade SIL is most often associated with low risk HPV, that is 6 and 11. Coming to the quadrivalent and nanovalent vaccine, which are active against HPV subtypes, that is 6, 11, 16, and 18, and also covers other HPV types, are usually decreases vulvar SIL. Perimenopausal patients are most likely to be associated with HPV vulvar HSIL, while as postmenopausal patients are more likely to be associated with non-HPV, that is differentiated vulvar intraepithelial lesion. What are the other risk factors? Again, as we delve for cervical cancer, cigarette smoking and immunosuppression are more common with. So we have seen that VINs are more seen in HIV and other immunosuppressed patients. So it is likely that immunosuppression also plays a major role. So vulvar dermatosis, mainly lichen sclerosis, is a major risk factor for differentiated VIN. Coming to the natural history, if a SIL has been left untreated, it usually persists and progresses, or it resolves. As we see with CIN, or as we say for CIN, here also, vulvar CIL can also persist, progress, or it can resolve. So low grade CIL is usually a benign manifestation of skin reaction to the HPV infection, and it's usually is self-limited, and usually it will resolve within 1 or 2 years. Whereas vulvar high-grade cells are intraepithelial neoplasms and are estimated to be associated with approximately 20% of squamous cell carcinoma of vulva. So it is necessary that these high-grade cells are to be treated. With differentiated VIN, it has highest risk of progression as defined previously. Apart from that, the putative precursor, approximately 80% of keratinizing squamous cell carcinoma. So majority of the keratinizing squamous cell carcinoma will have a precursor lesion of differentiated VIN. So they need to be treated. Coming to the clinical presentation, a woman can present to us either with pruritus or pain or a burning sensation or a dysuria, or she might also tell that there is discoloration of her vulval skin, or they might frankly present to us with a vulvar lesion or a persistent or there might be an incidental abnormal cervical cytology with no abnormality identified in cervical biopsy. So the clinical presentation, apart from this, can be a totally asymptomatic woman presented with some other gynecological problem, but you notice to have that there is also a vulvar lesion. So how do we diagnose? As I said, clinical examination plays a vital role. If the skin of the vulva appears to have any abnormalities in terms of the color or the appearance, it needs to be examined thoroughly and also needs to be biopsied if you feel that it might be a pre-malignant lesion. So you can have a warty appearance of the skin as it's seen in the first picture. There might be a small warty raised lesions, or it can present with a red patchy lesion or a leukoplatic patch, or it might also have a melanotic patch. So all these lesions are very suspicious and needs to be biopsied with under anesthesia, that is under local anesthesia, to confirm whether they are a pre-malignant lesion. So how do we diagnose a visible vulvar lesion? You can carry out a vulvoscopy. It's nothing but a magnified examination of vulva as we do with colposcopy. You do a vulvoscopy where you, under the magnification, you see the vulvar skin lesion. Also, you can put acetic acid of 5% to see for any acetovitening or acetovite uptake is there. So what are the indications of vulvoscopy is that whenever there is a visible vulvar lesion or there is a persistent symptom consistent with vulvar squamous intraepithelial lesion with no visible lesion, or there is a persistent abnormal cytology with no cervical intraepithelial lesions. So as I said previously, any vulvar lesions found on examination or during a colposcopy or a vulvoscopy that is not known to be benign or looks to non-malignant body should be biopsied. And sometimes a vulva with multiple areas of abnormalities or what, you need to biopsy all the sites, and you cannot miss, you cannot say that I have biopsied this site and that is not required. And if the lesion is treated without the biopsy and does not completely resolve and is refractory to a defined course of empiric therapy, it should be biopsied to obtain a definitive diagnosis. For example, if you have thought that it is a candidiasis, or if you feel that it is a postmenopausal atrophic vagina or a vulva and you would have treated with hormones, but if the symptoms persist and doesn't resolve or it is refractory, you have to take a biopsy to confirm that it is not a pre-malignant lesion, even though there is no appearance of a skin lesion. So how do we treat low-grade squamous intraepithelial lesions? Need not be treated unless symptomatic. If they present to us with symptom, then only you need to treat. Otherwise, they usually resolve within 1 or 2 years. Whereas high-grade squamous intraepithelial lesions have to be treated as there is a risk of developing squamous cell carcinoma in them. Again, the treatment is dependent on what is the which is the site that is involved and how big is the lesion. The treatment can be excision, ablation, or a topical treatment. So this is the outlay of how to decide as to whether to go for excision or ablation or a topical therapy. So if the biopsy proven head cell of the vulva, that is vulvar head cell is there, we have to do a physical examination, and if the findings raise the concern of an invasive disease, despite the finding of high-grade cell on pathology report, if you find that the margins are raised, ulcerative, or irregular borders are there, then it is better to go ahead with a surgical excision. That is, a wide local excision is preferred, and excisional procedure, if macroscopical negative margin can be achieved, is preferred. If you feel that there is no red flag of an invasive lesion, then the next question that you have to ask is whether the patient is at risk of an invasive disease. That is, are there any other risk factors, that is immunosuppression, or there is a background of vulvar dermatosis, that is lichen sclerosis, or likely to be a differentiated VIN. In that case also, since the risk of progression is nearly 30 to 50% to a squamous cell carcinoma, you go ahead with an excision. If the answer is no for that, then you have to ask whether the lesion is in a critical or a sensitive areas such as clitoris or urethra or very near to the anal orifice? If the answer is no, and if they are amenable for excision and they are single lesion, then again it is preferred to excise than to ablate the lesion. And if they are not amenable for excision and you will be ending up compromising a significant length of urethra or the anal orifice, or there might be stenosis post excision, then you can plan for ablation therapy or a topical therapy. Again, if you don't think that it is not a single lesion, again you prefer ablation or a topical therapy, because multiple lesion excision might become difficult in that place. So, post excision or post ablation or a topical therapy, the next step that is very important is we have to continue the surveillance every 6 months for 5 years and then annually, because there is likely that the lesion might recur or the lesion might have a satellite lesion somewhere else which can progress to a squamous cell carcinoma in future. So coming to the excision, what are the principles of excision? Generally, it is performed when the lesion is focal or a smaller lesion. And the excision of the individual lesion with 1 centimeter margin generally provides a satisfactory cosmetic results. You need not aim for a bigger margin. If histopathologically 0.8 centimeter of margin is available, that is good enough. So in terms of depth of the excision, removal of epidermis alone provides sufficient depth for the treatment of head cell. So you need not aim to have a deeper excision. So provided the margins are clear. So for the lesions which are extensive and multifocal and highly symptomatic, particularly when there is a pre-treatment. For example, if you have treated with a topical therapy or a laser ablation or a smaller excision is done, and they have failed to control, then you might go ahead with a wider excision, that is simple or a total vulvectomy. Here it removes perianal tissue as indicated and usually includes the subcutaneous tissue. Whereas in the previous wide local excision, you basically aim to excise the skin alone, epidermis alone. The other part is skinning vulvectomy. Here again, you aim to remove the vulvar skin along relatively in the avascular skin, avascular beneath the epidermis, preserving the subcutaneous tissue. So skinning vulvectomy, simple total vulvectomy if the lesion is extensive and multifocal, or if the lesion is small, wide local excision is preferred. So these are the surgical excision types. So coming to the ablation, either you can do carbon dioxide laser or a argon beam excision ablation. So the indications for ablations are if you don't have any concern that the lesion has a pre-invasive disease in it, or if the lesion is not multifocal, if the lesion is multifocal, where you cannot afford to excise the entire lesion, or if the lesion is involving sensitive areas such as clitoris, urethra, or anus, or entire vaginal introitus, where post-excision there might be a severe stenosis. In order to preserve vulvar anatomy, you end up doing ablation. The limitation of ablation is, again, it is training is required before you plan an ablation. Equipment may not be readily available in all institutions, and tissue is ablated rather than excised. So the coexistence of invasive cancer must be carefully excluded. So we have to be very sure that there is unlikely that an invasive cancer is there inside. So deeper laser vaporization results in destruction of the skin appendages, which leads to hypertrophic scar formation later on. So that side effect should also be explained to the patient. Coming to the topical therapy and the options available to us. So topical immune modifier, that is imipamode, is preferred as an initial treatment for recurrent vulvar head cell. For example, if you have excised and it recurs, you can try other modality, that is topical imipamode. As initial therapy, prefer to avoid excision and ablation. So 3 to 5 times per week, we have to apply on alternative days for a total duration of 16 weeks. The most common side effect with topical imipamod is inflammation at the application site. So we also had a patient with persistent VIN. For her, the most common complaint was her itching never came down in spite of using immune response modifier. Though the biopsies showed that she had a good response, symptomatically she never improved. So another topical application is fluorouracil. It is rarely used. It is a last resort when all other therapy has failed. So fluorouracil creams cause chemical desquamation of head cell, and it can cause significant burning, pain, inflammation, edema, and also ulceration. So the side effects are more severe with 5-fluorouracil. So we need to be very careful while opting this treatment. So coming to the some parts of discussion as to what modality of treatment is better. So studies have shown that 2 randomized trials with 18 observational studies. This review article told that the complete response rate of 51% when you use topical imipamod with partial response of nearly 25% and a rate of recurrence of nearly 16%. So you need to be very careful that even though there is response, she has to be under surveillance as there is higher recurrence rate after applying imipamod. But it is also reassuring that 51% have completely responded. So a comparative study comparing clinical outcome evaluating the risk factors for recurrence. Again, it's a retrospective analysis of 303 patients with VIN treated in a single institute. So they have compared individual modalities, that is excision, laser ablation, and imipamod, and they have found to be they say that the combination of excision and laser evaporation was associated with significantly worse recurrence-free survival, but all the individual treatments had equal effectiveness on multivariant analysis. So they say all modalities are equally effective. So coming to the surveillance post-treatment, after the treatment is completed, either excision, ablation, or focal application, long-term surveillance of the entire genital tract is mandatory, given the possibility of later recurrences. In one study, almost 800 patients of high-grade VIN, 26% had recurrence rate was observed, and 8% of them, of those recurrences were progression to cancer, and 25% being late recurrences. So it's very, very important. It's just not the treatment, but the surveillance has to be very good. So coming to the take-home messages, the International Society for Study of Vulvovaginal Diseases have labeled VIN into 3 categories: VIN low grade, VIN high grade, usual type, and differentiated VIN lesions. The high-risk factors of vulvar head cell includes HPV, cigarette, smoking, and immunosuppressions. Any lesions on vulva that is not known to be benign warts has to be biopsied, and if it does not resolve also, you have to biopsy it to make sure what is the exact cause of that lesion. The goal of the treatment is to prevent development of invasive vulvar carcinoma and to relieve the symptom while preserving normal vulvar anatomy and function. So the treatment has to be individualized based on the examination and the biopsy results, prior treatment history, and also the location and locality of lesion. Before I thank, so we have presently admitted a patient who came with mild itching, but more of discoloration. She presented to us. When we had a biopsy from this leukoplatic patch, it came as high-grade VIN. So if you see that she has multifocal lesions, a lesion here, a red lesion here, and also another ulcerative lesion here. So we had biopsied all 3 lesions So one of the lesion is high-grade VIN, other is also high-grade VIN. Whereas the lesion in the posterior labia minora on this side is actually a squamous cell carcinoma. So it is very important to biopsy, even though if it is multifocal lesion, to make sure that we don't miss any differentiate or we don't miss any carcinoma in situ or a carcinoma in that patient. With this, I would like to thank and conclude my presentation.
Thank you, Dr. Arpita, for this wonderful presentation. Arpita,
Yes.
I have some doubts. Can I just ask you those questions? See,
Sure,
one is,
ma'am.
see, normally we tell people, because all these, I mean, to this audience, whoever is there, most often these cases are being seen by gynecologists, and only there, from there on, we take a biopsy, and then we have a suspicion, we refer them to oncologist. So, like how the Dr. Arpita showed, especially in the last slide, we might only take a biopsy in one particular area and then miss the other lesions. So that's very important. Now, you said biopsy. How do you normally advise people to take a biopsy?
So,
What is your, how do you take? Will you take with the rallies, just take a biopsy and do a suturing, or how do you take a biopsy?
so we take a biopsy under anesthesia in the side room
Local, yeah.
under the local anesthesia because it's a very sensitive place. And a wedge biopsy is taken from the lesion with next skin where you feel a normal tissue is also there, an abnormal tissue is also there, so that the differences can be made out from the pathologist side. In terms of invasion also, it's usually advised to take a wedge biopsy at the edge of the lesion.
Actually, here the dermatologists use a nice punch biopsy process. So it's nice, it goes deep inside. So you'll be able to get a good bite. You have different sizes of these punch biopsy forceps. You just have to put it there and then screw it. So you'll be able to get a good depth of the tissue, because when we take a, wedge biopsy, the depth may not be sufficient. Punch biopsy, for it's called a KEYEES.
Heels.
Keys punch biopsy forceps. So we normally use that. So it's a very small area, but the depth is good. So it's especially when you want to take in multiple areas, I think that can be used. And the other one, like you rightly pointed out, it's very important that we take multiple biopsies, especially if the lesion is multifocal. Now, how do you make out that is multifocal? In this case that you showed, it was okay. But suppose it's a HPV associated lesion, it may not be so apparent, isn't it? So it's likely that we might miss these cases. So how
Yes,
do you
ma'am.
make out? So you tell us how you make out that is multifocal. Are there any other things that you can do? Any other examination? What about the use of colposcopy?
Yes, ma'am. As I said, apart from the gross examination, you can, in case where you are not seeing any visible lesion, as in this case, you can take her to the colposcopy room and see under magnification if there are any lesions. As I didn't cover the vulvoscopy per se.
The
Vulvoscopy,
triple
you
ring
divide
vulvoscopy.
vulva into three different categories.
The triple ring
Three
vulvoscopy.
circles you define. Yes, triple ring vulvoscopy, where the outer ring, inner ring, and the central ring you define, and you examine each ring separately, either using acetic acid alone or acetic acid with toluidine blue. Uh, so you can make out the margins or abnormal uptake of acetic acid with 5%, and wash away with toluidine blue. You can see a positive margin. You can take the lesion biopsy.
Okay, yeah. So that's it. I just wanted to emphasize, because all of us, if we see a lesion, we tend to take a biopsy from that particular lesion. We never tend to look and see whether it's multifocal. So one take-home message, all of us must look for to see whether it's multifocal. Apart from it, I think it was a very wonderful presentation where you brought out the difference between a HPV associated lesions and a non-HPV associated lesions. And if it's non-HPV associated, though it's very rare, the chance of it become malignant is very, very high. Now, suppose you identify a lesion as lichen sclerosis, what do you do? You take a biopsy. Any idea how you would treat it? Arpita, are you there?
Arpita?
Arpita?
Yeah, she's lost the connection, ma'am.
Hello.
Okay.
She's
I
there.
lost it.
Because very
What was the
often,
last question, ma'am?
yeah, I asked, supposing we take a biopsy, we identify it's a suspicious area, we
Hello.
take a biopsy, and the report comes as lichen sclerosis, because most of us, the report will come as either lichen sclerosis or lichen planus. Sometimes only it will come as VIN. So if it comes as lichen sclerosis, what do you do? Though it might be a dermatologist, from your point of view, what could you do? If it's lichen sclerosis.
Okay, so for the lichen sclerosis, what we usually recommend is actually we take a second opinion from a dermatologist, but usually the topical steroids, that is clobetasol, is what is recommended for lichen sclerosis. In patients with lichen planus, you need to give both steroids with or without systemic immunosuppressants. So topical, high potency topical steroids, that is clobetasol, is usually recommended for lichen sclerosis. So again, if you have a background of lichen sclerosis, we usually do a vulvoscopy and see for any lesion is there. Make sure that there is no lesion, and then only give them lichen sclerosis treatment. That is clobetasol.
Okay. Now you said these patients with lichen sclerosis are the ones who are going to develop into the DVIN.
Differentiate. Yes,
Okay.
ma'am.
So in such cases, how do you know whether this particular person with lichen sclerosis is going to develop DVIN? How long will it take?
That part, what you usually see is after lichen sclerosis is developed, you tell them to apply for topical clobetasol, and you ask them to be under regular follow-up in case the symptoms are there. If the architecture changes, if the patient is understanding and is educated and she is compliant for your medication, it is better to be kept under surveillance. But I am not sure as the duration of lichen sclerosis and the incidence of pre-invasive lesion.
Because
That
how do you keep them? We just keep on seeing whether the lesion decreases or it increases. If it increases, then maybe you have to take another biopsy. Is it like that?
So for all lichen sclerosis, you need not treat. You need not be under surveillance. If you feel it is, you can tell them if the lesions appear on your vulva, or if you have any symptoms of itching or burning sensation, you please report to us. Lichen sclerosis per se might not be symptomatic. When the symptomatic, they have to report to us.
Chitra madam, only one question, Chitra madam.
Yeah, madam.
Arpita,
Yes,
can we
ma'am.
see this vulval lesions with the colposcopy? And can we repeat the biopsy as Chitra madam is telling, once in 2 years? Is it so? It has to be repeated till lifelong?
No, they don't recommend for repeating biopsy once in 2 years. They only say that they have to be kept under surveillance for any development of new lesions. Biopsy might not be indicated, but if you see that patient is still symptomatic and you're not finding any lesion, it is preferred to do a vulvoscopy.
No symptom means we can leave it.
If the no
Okay.
symptom, you can leave it. But if there is a symptom, or if you feel that there is a lesion but still asymptomatic, either ways, better to do a vulvoscopy to confirm it.
What
Thank
about
you.
Paget's disease?
Paget's disease I didn't cover because of lack of time. Paget's disease is a rare, slow-growing pre-malignant or a malignant condition involving vulva. It is a form of intraepithelial adenocarcinoma that accounts to less than 10%, less than 1% of vulvar neoplasm. So it is, rather you can be very specific to say that it is a rare intraepithelial neoplasm of apocrine glands
No,
origin
in the
affecting the
pre-malignant
vulva.
lesion, this also has to be included, isn't it? Paget's disease?
Yes,
Pre-malignant
ma'am.
vulvar lesions.
Yes, ma'am. I wanted to cover the dermatosis VIN. Apart from the VIN, the classification, the dermatosis, lichen sclerosis, lichen planus, and Paget's disease. Again, another 20 slides are there with me. If time permits, I can do it.
Okay.
There are some questions on the chat box, Arpita. So I've asked, can you please clarify when we should prescribe mode?
Dr. Chitra, I just wanted to share one information. See, when I trained in Holland for my fellowship, we used to see many cases of CA vulva. And I mean, just like how we see CA cervix here, the incidence of vulva used to be more. So for every case of CA cervix, they used to have 5-6 cases of vulva. And it was really surprising. And almost 50% of them used to be after this lichen sclerosis. So maybe there is some amount of genetic predisposition between the populations also. That also may be an answer. But when I tried to read into the literature, I didn't find any information like that. But I think probably genetic predisposition. As such, we are more prone for cervix, and then our population is more prone for cervix and vulva, and maybe that Western population is prone for vulva. I really don't know. And the incidence of sclerosis also used to be more, and they used to keep these patients under follow-up. They used to come and then meet every 5-6 months once, the sclerotic patients, when they are on treatment. And once the lesion completely disappears with steroid treatment, then they used to be let off and then come report back again when they are having symptoms like itching or any lesion on the vulva. This is the way they used to follow up the patients.
So, like cancer cervix, HPV vaccination, we are telling for vulvar cancer also, since human papilloma virus is the cause, we say in younger population, we must create awareness about the HPV vaccination in the adolescent girls.
Yes, ma'am.
Padma, you are
there are
doing a
two
lot of work,
questions.
no? HPV vaccination. So you must make awareness about this vulvar cancer also in young girls, HPV infection, genital warts and other things.
Yeah, definitely.
One question, no?
Yeah.
Arpita, there's some in the chat box. Can you tell us when you have to prescribe imiquimod?
Okay, so again, follow that flow chart which I told. If the lesion is not looking like an invasive lesion, or if the lesion is not multifocal, if the lesion is unifocal, you can excise it. If it is multifocal, not excisable, or if it is looking like a pre-invasive lesion, requires excision, go ahead and excise. If you think it is not looking aggressive lesion, or it is multifocal, you cannot excise, then you can treat with imiquimod.
16 weeks. 16 weeks you said, no? You said 16 weeks?
16 weeks.
Yeah, the slide you had showed it, Arpita?
Yes, ma'am. Yes, ma'am.
Period of 16.
Then the other thing is, supposing you excised and then the margins are positive, do we need to repeat the excision or use frozen section?
If the margin is a high grade VIN, it's better to repeat the excision if it is excisable. If not, if it is not amenable for excision, you can try ahead with imiquimod. If it is excisable, better to go ahead and excise. Do we need to
They've
suture
written
it?
after wide local excision, we've done an excision of the lesion. If the margins are positive, then what do we do? They've already excised the lesion, but the margins are positive. In such cases, what will you do? Will you repeat the excision or will you? I don't know why they've written frozen section. Because the biopsy has come, then there's no point of frozen section, isn't it?
Yes, yes. Maybe they are asking whether
what will you do
first
next?
excision, do you take a frozen section?
Yeah.
So usually we don't go ahead with frozen section. We try to keep a margin of 1 centimeter, gross margin, then only we excise. So usually the margins won't be positive. In case in critical places where it's very close to the urethra, margin might become positive. In that case, you can go ahead and give imiquimod. Hoping that the margin that you are referring to as is pre-invasive margin only and not a carcinoma. In case if it is carcinoma, you have to either treat with, depending upon the area and the stage, you have to proceed with radiation or you have to excise, pre-excise.
In such cases, skinning valvectomy enough? It depends on the depth.
Skinning valvectomy for high-grade VIN is enough.
Okay.
Following a biopsy, if there is bleed, do you suture it? They've asked.
Yes, we have to suture it.
We usually suture.
Usually suture.
And then follow-up you have answered. And next is lichen sclerosis are plain as quite common in the OPD. Do you biopsy each site and in which situation?
Again, in lichen sclerosis and lichen planus, in that case, you need not biopsy each and every patient in case they are not responding to treatment. In case you find a suspicious lesion, then only you have to go ahead and biopsy. Actually speaking, if you see, if you do a surveillance of your OPD, high dependency OPD, usually you see at least 5 or 6 patients with lichen sclerosis in every OPD. So we don't biopsy all patients with lichen sclerosis. Only when there is a lesion, either leukoplatic patch or an erythroplatic patch, or there is an ulcerative margin, or the skin appears abnormal, then only we biopsy. If the patient complains persistent pain, then you can take her to the vulvoscopy, do a vulvoscopy, identify the lesion and biopsy.
One question they written, sometimes VIN is in continuation with VAIN, vaginal lesion. What can we offer? Excision?
Yes, in that case, it's the excision, and again depends upon the area of your vaginal lesion. Usually, vaginal intraepithelial lesions again is classified as the similar way of VIN. Treatment also is almost similar to that. You have to excise it.
When do you call suspicious lesions in lichen sclerosis?
So suspicious lesion in lichen sclerosis. If possible, I'll share one slide of lichen sclerosis.
Yeah, you can. You may.
I'm unable to find. I have opened the chat.
Okay.
Is it seen?
Yeah. You just put it in the slideshow mode.
So in lichen sclerosis, usually lichen sclerotic lesion looks like a deformed, eaten up labia minora or a majora. So if it is uniform and uniformly eaten up, it's okay. But you will be able to identify an ulcerative lesion or a raised margin or a leukoplatic margin. Then it is the area needs to be biopsied. Yeah. So I think. So see here, here again you see that the surface is not regular. You can see that there is some erosive lesions here and there. So it is better to do either with vulvoscopy, identify the lesion with acetic acid, and then you can biopsy. If the lesion is clearly defined, raised margin, even in the case which I told in the last slide, you can see that a margin like this, if it is defined. Here again, if the margins are defined, you can do. It might look like this. This is not a lichen sclerotic lesion. If the margin is defined, a lesion is identified, you can directly biopsy, or if you can do it with a vulvoscope. Yes. Ma'am, any other questions for that?
There is one more question. When do you call suspicious lesions in lichen sclerosis?
That's the one which I answered.
Oh, yeah, you answered. Management of leukoplakia.
Leukoplakia, we usually see for any we biopsy the leukoplakic patch to make sure that it is not a pre-invasive lesion if they are symptomatic. Not all leukoplakia needs to be biopsied. And if the lesion, if it is a normal skin, you need not treat any all leukoplakia. The treatment is not warranted for all leukoplakic patch.
Someone has asked, can you show?
Vulvoscopy.
Yeah.
Vulvoscopy, do you have?
Yes, ma'am.
Do you have a vulvoscopy? Oh, yeah.
Yeah. So
Can you
as
put it on the full screen mode, slideshow mode?
So it is the same procedure. You put it in lithotomy and the colposcope with acetic acid and iodine, or you can use toluidine blue. The boundaries, anterior, posterior, and lateral boundaries are made. The three-ring technique is used, where you define the outer ring with mons, pubis, and labia majora, the middle ring with labia minora, and anterior and posterior commissure, and the inner ring beyond the hymen. So the outer ring, middle ring, and inner ring will cover. Means it's a systematic examination of the vulva. You don't miss any lesion. So that's why you do a vulvoscopy. So this is how we depict a vulvoscopic findings. We broadly classify whether there are symptomatic patients or asymptomatic patients, and specific findings or a non-specific finding, if any, you can find. You will label them either as lichen simplex, chronicus, or sclerosis, or planus, or psoriasis, or pemphigus. So these are the way you label them. So again, do I need to cover all this, or I just broadly wanted to say what is vulvoscope?
No, they wanted to see how so it's the same colposcopy which you're saying as a vulvoscopy, is it? See, they just
In
want
colposcopy,
yeah,
there is
yeah.
a video made by my senior. If you want, I can just project it.
Yeah, no, they wanted to know, is a vulvoscope different from a colposcope? Is it the same?
It's the same. It's the same. See,
exactly.
colposcope is nothing but magnified visualization of cervix. Vulvoscope is nothing but a systematic and a magnified imaging of vulva.
I think
in
that's what
order
they
to
want
identify
know.
the lesion.
Yeah, they want to know was it different?
So
Yes,
if
ma'am.
you have a video and if it is not of long duration, probably you can show that.
I'll just try, ma'am.
The audience, yeah.
Just a minute. Is it visible, madam?
Yeah.
So the things that we take is the kidney tray, a sponge holder, 5% acetic acid, 1% acetic acid, and less than 1% toluidine blue, and catgut in case if you take a biopsy and you will have to suture it. So you dab the vulva with saline, normal saline, and you identify the outer ring. It is labia majora, mons pubis, and the opposite side, labia majora. And you identify the middle ring involving the clitoris, labia minora, anterior and posterior fortune, and the inner ring, that is at the edge of the hymen. So the first step is putting acetic acid. We use 5% here, whereas in cervical cancer screening, we usually prefer 3%. You can see that there is some amount of aceto-white areas in the middle ring. You can see that intense aceto-whitening is also seen there. So following this, we wash the acetic acid with 1% toluidine blue. So after this is after application of acetic acid. So the lesion is then again washed with 1% acetic acid after that. So you can see the normal epithelium retains its texture and color, whereas toluidine blue staining in suspicious area is noted. So those areas we biopsy it. So that was, I would like to acknowledge Professor Lata Madam and also my student Vikramaditya who had made that video. Ma'am, was the video audible and
It was nice. Now there's one question. Where do you get toluidine blue? Where is it available?
usually we prepare here. So it's I think the central stores here prepares with the powder, the percentage. So it is prepared in-house.
So it was a very nice presentation, Arpita. I don't see any more questions now. So can we finish it? Now it's almost 5:10. Chitra madam?
Yeah, it was really
Madam.
wonderful. There's only one last question. Please show heart's line. I think we'll omit that. Because that is
She's already
the
completed the video, no?
Okay.
Do I need to open it again?
So probably that three areas you can show.
Yes. Okay.
So, Dr. Arpita, I think that's the end of it, but it was really a wonderful presentation. See, the message that is that we should not miss any lesions. We should have a high degree of suspicion, any abnormal areas, because vulval lesions could be in different colors and different shapes and sizes. All lesions which are looking abnormal, which are different color, we should make it a point to take a biopsy, isn't it?
Yes.
Okay.
Yes.
Thank you so much, Dr. Arpita, for this wonderful talk that you gave us. Thank you so much. And thanks, Dr. Padma, for having invited me for this wonderful webinar to be a chairperson. Thank you so much. It's a pleasure.
Thank you, Padma.
Yeah.
Thank you, Arpita. Nice presentation.
Thank you, Arpita. It was
Thank
a
you.
beautiful presentation. And thanks to Dr. Chitra and Dr. Chandru madam, who really made it more interesting. And today's delegates also, they came out with lots of questions. I know how much of interest this webinar and your talk has generated, because it's quite a little very rare situation and everybody wants to know more about it. I can understand the urgency of that, seeing the number of questions we have today. And Arpita, it was really awesome and very good. And it was very thoughtful of you to have the vulvoscopy also recorded and showed to all our delegates here today. Thank you. Thank you so much.
Thank you so much.
And I thank Dr. Radhika. I think she has some work and then she has left her MOC today. And Dr. Sampath madam also who joined here today. And I thank all the delegates who have joined in good numbers and for all asking such exciting questions also. I also learned a lot today. Thank you. Thank you one and all. And I think we'll finish it now. Yeah. Thank you.
Thank you for the opportunity, ma'am. As said, I also my key area of interest is prevention of cervical cancer also. So I do a lot of research on optical and electrical impedance based diagnosis of cervical cancer. If you have time, in any time, I would like to talk about that also in future.
Definitely. Thank you,
Sure.
Arpita. Thank you. And
Thank you for the opportunity, each and every.
Yeah. Thanks to the Shield people, Tnfog, and Shahiti for helping out with this webinar. Thank you one and all, and have a good evening, nice evening to all of you. Thank you. Bye.
Thank you.